All right, welcome into the review session for the HESI. What I've kind of done is I've gone through the NCLEX book. It'll be a physical version for you guys if you have it, but I've kind of gone through and put stuff down that I think is really important. Obviously, we can't go over every single thing. A lot of the stuff for studying for the HESI, I know that you guys have the MedSurg 1 test first. It's going to be a lot of kind of what you're thinking you're maybe struggling on. For example, I feel like exam 3 content you guys are very strong on, so I wouldn't necessarily go back over it. I'd go through more of the prenatal stuff or the labor and delivery experience stuff to kind of review for the session. Whenever it comes to a lot of this content, yes, you could have questions on it, but when it comes to a lot of the postpartum content, I really think that it's going to be lots of teaching, lots of questions around, especially when it's postpartum questions. It could be an example of like a mother explaining something, and then all of a sudden they're wanting you to teach if that's normal or not, or what they should do. Or for the example that I used last week, for those that were in person, we talked about how with some of the questions around postpartum depression, stuff like that, you might have a husband that's kind of voicing a concern, and they might be asking, what do you think that is? And you're kind of saying something to the husband of the patient. So questions like that. And it's, just typical HESI questions, but we're going to be starting out by going over the prenatal type of experience, and I'll try to share my screen here. Okay. Alrighty. When it comes to prenatal, of course, if you do have any questions over just vocabulary, that could be make or break for some types of questions, just because it's been so long, and I do understand that. Of course, you might have a Nalgene's rule question. Of course, understand. Of course, it's going to be subtracting 3 months and adding 7 days, and just go back and just do one example of that, and you'll be good. Whenever it comes to the gravida, of course, that's the number of times a woman has been pregnant. And pay attention, because sometimes a question is going to have it where it'll say a pregnant client has come into the room. So you kind of already have to add a gravida to that, okay? Parity is the number of births carried past 20 weeks of gestation, regardless of being born alive or not. If they use the term nullipara, of course, that's a woman who has not given birth at more than 20 weeks of gestation. Remember, of course, the GTPAL, you could have a question on that, and I feel like that would be kind of a gimme question, because once you kind of get it, it's pretty reasonable with that. Of course, G is gravida. Term is term births, the number born at term. So we're thinking longer than 37 weeks. P is preterm, whenever it's in the GTPIL sequence. Preterm is born before 37 weeks. A will be abortion or miscarriages before that 20-week period. And then L is the number of living children in the household, for living children. Whenever it kind of goes back into the stuff with the signs of pregnancy, presumptive is going to be subjective, a missing period, nausea, vomiting, the increased size, maybe they're feeling full, having to go urinating a lot, or they're quickening, the first perception of a field movement when they're thinking they're feeling something. Once we get into the probable, that's objective signs. So it could be, we go into the HCG. Hagar's was the softening, and then it goes into C for color down here. Chadwick's sign, that violet color of the cervix that will change beginning at around 6 weeks. And then G, Goodell's sign, is the softening of the cervix. If you ever have a question on that, just put them in the order. H, associate that with the uterus, it's going to be at the top. C is, of course, color, and then G is going to be at the bottom, the softening of the cervix itself. That's what I would do. We have a question here on an example of a estimated due date thing. If you need to pause the video and do that. Maybe a little bit more. When it comes to if they're ever talking about any positive signs, diagnostic signs of pregnancy, that's going to be, of course, whenever they first determine a fetal heart rate using a Doppler. If there's any palpable signs, or if there's, of course, it's on a on an X-ray, of course, they could see through and things like that as well. In terms of fundal height, we're using it, of course, in the first couple trimesters to evaluate the size and how, if it's going to be a really big baby, things like that. Starting out with B here, it says during the second and third trimesters, the fundal height in centimeters is approximately equal fetal age, and the weeks, of course, plus or minus 2 centimeters as well. At 16 weeks, the fundus can be found halfway between the symphysis pubis and the umbilicus here. We have it right here. At 20 to 22 weeks, the fundus is approximately at the location of the umbilicus. And really, guys, when it comes to these questions with the fundus and stuff, you might have a couple, but I don't think this would be something to kind of put all your cards in. It's just if it's a little confusing, just kind of maybe just memorize a little patterns here. Of course, that it's increasing and things like that, and that's what help you a lot. We do, I mean, this stuff all goes back into exam 1 stuff, but we'll keep going a little bit more. I'm going to skip over these system changes because that would stuff I would say just give it a little read over if it's kind of making sense. Okay, whenever it comes to questions about the cervix, you could very well have that. The cervix is becoming shorter, more elastic, and larger in diameter. We are having what's called the mucus plug, if that goes back into your brain. Whenever the dilation process begins, that mucus plug goes away. But the mucus plug was there previously to kind of prevent from any infection that can occur, any bacteria getting in, things like that. Alrighty. Okay, whenever it comes to the physiologic changes, I would say that definitely I do remember having some questions or just some discussion on a question about the ambivalence of pregnancy. It is usually occurring early in the pregnancy whenever it is, or even if it is planned. It's really just a experience of a change in life coming, an experience of a dependence-independence conflict related to the role changes of their entire lifestyle. The partner may experience this related to the new role being assumed. They're increasing financial responsibilities and sharing the mother's intention with the child. I remember back whenever Harold, the way she would always kind of approach this was like, if they're talking about finances, let's focus on that later. Let's focus on what we can change right now with that. Of course, then we're going into acceptance, then into emotional lability. It is manifested by the frequent changes of emotional states or extremes and emotional states. These emotional changes are common, but the mother may think that these changes are abnormal. Just kind of using some TC if that was ever something that they're asking on with that question. Well, of course, whenever it comes to a lot of the body image changes, teaching that this is expected, and that would be something very similar. Just really TC if it's a prenatal checkup and the mother's voicing her concern over some body changes, being that the changes in a woman's perception of their image during pregnancy, and this could be positive or negative. The second trimester, they're usually very glowing, and they may have already accepted those changes, and they're just really, whether they're just in the moment, they're just kind of glowing in that kind of phase. With just normal vocab with skin changes here, I would feel like that would be pretty important as well. We might have the linea nigra, the dark streak down the middle of their abdomen, chloasma, which is also called the mask of pregnancy. It's that hyperpigmentation of the skin over their face, the cheeks and their nose. And then, of course, they're having stretch marks as well. And this usually does fade away, and you can also teach that as well. Okay. When it comes to the discomforts of pregnancy, this was actually one of our assignments back in the early semester. So I'll just go over the interventions because that is a lot of what your questions very well could be over. With nausea and vomiting, encouraging dry crackers before arising, avoiding the brushing their teeth immediately after arising. If the question's talking about that they're eating 3 large meals a day, kind of encouraging to kind of change that and to then go into some small, frequent, low-fat meals during the day. Encouraging fluids between meals rather than at meals. Avoiding those spicy foods, and just asking if they're using any herbal remedies. With the syncope, encouraging that they're sitting with their feet elevated, and teaching about risk for falls, that they need to kind of change their position slowly rather. Whenever it comes to the urinary frequency and urgency, this is just, the entire bladder is kind of getting compressed on. So this is this is a natural thing. And this can be in different trimesters. Of course, in the 3rd trimester, you have the baby that's weighing down, but just kind of teaching to drink no less than 2,000 milliliters of fluid during the day, limiting the fluid intake in the evening, so they're not having any, wet times at night, making sure that they're taking time every hour to go to the bathroom at frequent intervals, just to kind of prevent having to go when it's not really necessary, or not necessary, but when it's like a problem, I would say. If necessary, encouraging wearing pads, and of course, performing Kegel exercises to strengthen their abdominal muscles. I'll go into fatigue next. With fatigue, try to encourage them to kind of take rest periods and to perform muscle relaxation for their legs and their hip joints, and avoiding eating those stimulating foods during pregnancy as well. Stimulants, sorry. Heartburn is a pretty big one, I would say. Whenever it comes to heartburn, encouraging them to, of course, having small frequent meals, to sit upright for 30 minutes after the meal, not to go into the, not to lay down, of course, right after meals, avoiding those spicy foods. And then, of course, if they're having, or if they are on any antacids, to kind of talk to their provider about that as well. With ankle edema, elevating the legs at least twice a day and when resting, sleeping in a side-lying position, wearing those supportive stockings, and avoiding sitting or standing in one position for long periods of time. With the avoiding standing for long periods of time, that really goes into also varicose veins. We're kind of taking those same interventions as well. With headaches, changing positions slowly, applying a cool cloth to the forehead, eating small snacks, and acetaminophen only if prescribed by the healthcare provider. Alrighty, with our hemorrhoids, for interventions, this is going to be soaking in a warm sitz bath, sitting on a soft pillow, eating high fiber foods, and drinking enough liquids to avoid any constipation that could occur and worsen their problem. With constipation, we're going to be eating high fiber foods such as whole grains, fruits, and vegetables, drinking no less than 2,000 calories per day, and taking some walks as well to kind of get active, get the bowels moving, things like that. Alrighty. With our backache, sufficient rest, wanting to use correct posture and body mechanics, and doing some exercises, sleeping on a firm mattress in a side-lying position as well. With our leg cramps, this is occurring in the 2nd and 3rd trimester. We're wanting to just really take some time to walk, dorsiflexing the foot of the affected leg if that's occurring, things like that. I'll go into 7. Okay, this is a big topic. I feel like that definitely could be on your exam. And this falls into a lot of our exam 1 content as well, with the non-stress and the contraction stress test. Starting out with the non-stress test, this is just to look at the fetal well-being. This is definitely something that's definitely pretty simple. It's non-invasive. The way all this goes is they're really much determining a baseline, and then they're going to be kind of just seeing how the fetus kind of reacts to this. So we're going into the results section. The reactive would be a healthy fetus. This result requires 2 or more fetal heart rate accelerations for at least 15 beats per minute, lasting 15 seconds from the beginning to the end during that 20-minute period. If this was abnormal, this was where there's, well, a healthy fetus is going to be accelerating their heart rate. This is when we're having no accelerations, or the acceleration itself is less than 15 beats per minute, lasting less than 15 seconds in duration over a 40-minute observation. Okay. Going into a contraction stress test, this is when we're assessing the placental ability of providing oxygen to the fetus. So pretty much during contractions, every single time they're having a really big peak of a contraction, we're wanting to look at the heart rate. So this is kind of a test of that to see how it's going to go further hand. Going into the results section, a negative test would be normal. A negative test results in no late decels of the fetal heart rate. A positive contraction stress test would be abnormal. This is when we have late decels occurring with 50% or more of the contractions in the absence of hyperstimulation of the uterus. And I would say just focus on those two for your HESI. When it comes to risks of related to pregnancy, we're going to talk about diabetes because I feel like that's very much an important topic for your HESI. When it comes to diabetes, pregnancy places demands on carb metabolism and causing insulin requirements to change. Keep in mind that when it comes to the placenta, glucose crosses, but insulin does not. I've seen a few questions on that before on just practice questions related to the NCLEX. The fetus provides its own insulin and pulls glucose from the mother, which predisposes them for hypoglycemic reactions. I've always used the example of the baby's been sitting in a, the pool of sugar, and they're suddenly removed from that area, and now they're at risk of hypoglycemia. So pretty simple way to put that. The newborn of a diabetic mother may be large in size, but the functions related to the gestational age will be rather normal for that gestational age. Of course, the newborn is at risk for hypoglycemia, hyperbilirubinemia, respiratory distress syndrome, and congenital abnormalities. Here we go with our diabetes or gestational diabetes. This is, of course, if our mother is pregnant, and then, of course, at that time between 24 and 28 weeks, they do that screening and they have a positive test. The 3-hour oral glucose tolerance test is performed to confirm this. Gestational diabetes frequently can be treated by diet alone. However, some clients may have this where it starts and it never goes away. So they might be eating some insulin and stuff like that. Of course, we already understand diabetes whenever it comes to the 3 Ps, but for interventions, we're encouraging a different diet because diet, whenever it comes to type 2 or gestational diabetes, a simple diet change can really change a huge course for their entire assessment and the actual patho of their progress. Okay, for interventions during labor, we're monitoring their fetal status for signs of distress, and if noted, preparing the client for if they needed a C-section as well. Just because diabetes and pregnancy does kind of put some stress on the placenta, so that's kind of where we're preparing for that if things kind of go south with that as well. With postpartum period, we're observing the mother closely for a hypoglycemic reaction because a precipitous decline in insulin requirements occur normally after the first 24 hours. There's that. I'm going to scroll down to ectopic pregnancy, because that's a pretty big thing as well. With ectopic pregnancy, it's pretty much where it's been implanted in the incorrect place. This is whenever it's still in the kind of, it's kind of up here, it's just the wrong place. It's whenever it's in the tubes itself still. Most common location is in the ampulla of the fallopian tubes. This would definitely still have the same kind of assessments that would be subjective, but we will have to be prepared for a potential rupture once that kind of grows. That's kind of the teaching with that. To kind of treat this, they're usually going to give methotrexate, a antagonist, and it's going to be it's going to be kind of destroying those cells and things like that as well. Okay, whenever it comes to our HIV teaching, I'm going to be going towards the newborn and HIV, because I do know that we had some questions on this and students were asking questions, but the neonates born to an HIV positive client may test positive because the antibodies received from the mother may go up for 18 months after birth. They are going to need antibodies for the infection, but not all of them are going to be acquiring that infection as well. Whenever it comes to interventions, we're going to be giving a sufficient bath. And then of course, when it comes to the rooming itself, I've seen questions where it's saying that they can't be together, but they can be together. So that's what I wanted to kind of stress with that. The newborn can room with the mother itself. With hyperemesis gravidarum, whenever we're thinking this, we're thinking fluid and electrolyte imbalances because they're having lots of persistent vomiting. This is pretty much the path of this is whenever their HCG levels are through the roof. It's just like morning sickness, but a lot worse. So whenever it comes to the interventions, we're doing INOs, we're counting their weight. We're also going to be monitoring the fetal heart rate for any complications because they, of course, are losing a lot of their electrolytes and they could go into cardiac problems as well. We're going to be putting some IVs in, we're going to be initiating fluids, and also we're really wanting them to kind of sit upright after meals. Whenever this was in our exam content, we pretty much went over this a lot, but I just wanted to bring that back. We have the otherwise called Molar Pregnancy. This is whenever this is a form of gestational trophoblactic disease. They kind of go hand in hand. The mole, of course, this is what it looks like, a little snowball on the scan itself. So with the interventions, we're preparing the client for a uterine evacuation. This is whenever it's kind of, it showed signs that it was a pregnancy at first, but it actually wasn't. And this could be a definite a sign of cancer as well. So they kind of have to do lots of teaching, lots of making sure that they're definitely removing that precisely to kind of get all those tissues out of there as well. Okay, within gestational hypertension, a lot of this, I would say they kind of go hand in hand. Whenever you're looking at an exam question and they say that, sometimes we're thinking of preeclampsia. That's kind of what it would be too, because it just kind of goes into the other. Whenever it comes to our complications of this, we have a bunch. We have placental abruptions, we have DIC, we have thrombocytopenia, any placental issues because it's kind of tight, that placenta itself, and it's just kind of cutting off circulation as well. We also do have HELLP syndrome, the hemolyzed, elevated liver enzymes, and low platelets. Kind of going down. Whenever it comes to our interventions, we're going to be monitoring their neuro status, because that if we're going into eclampsia, this is whenever we're getting to possibly an impending seizure. As far as your tests, whenever it comes to this stuff, I would say don't really stress over that. I don't think they're going to ask you mild versus severe preeclampsia. Okay, going into incompetent cervix. This is whenever we have a cervix that kind of prematurely tends to dilate. So what we're going to do is we're going to do a cervical cerclage. That's going to be kind of gone in there. And it's going to be kind of preventing that from kind of occurring again. This is in which a band of fascia or a ribbon is placed around the cervix beneath the mucosa to constrict the internal occiput sacrum. I think that's what it is. This, of course, is removed at 37 weeks or left in place and a C-section is performed. If removed, the cerclage must be repeated with each successive pregnancy because, of course, the number one kind of precursor of preterm labor is previous preterm labor. So we have to really kind of keep that in mind with that. With a lot of our torch infections, I would say understanding that a lot of these are at risk of preterm labor, spontaneous abortions, and it's kind of going to be teaching with this stuff. So, of course, toxoplasmosis is through raw meat or handling of cat litter infected cats, and this organism is transmitted to the fetus and it can cross placenta. The other infections include HIV, syphilis, things like that as well. But with rubella, this is a teratogenic organism in the first trimester, so we have to be careful with that. This definitely could cause congenital defects of the eyes, heart, and the brain, because if you're thinking about trimesters here, during that first trimester is when all of those things are kind of formed. So it is, of course, going to go ahead and cause and congenital defects if that baby was to, of course, be still viable after that experience. With rubella, if not immune, so the titer is less than 1 to 8, the client should be vaccinated in the postpartum period. And of course, the client must wait 1 to 3 months again before becoming pregnant as well. With cytomegalovirus, this is an organism that is transmitted through close personal contact. It does have the ability to cross the placenta as well, and the fetus may be infected through the birth canal. The mother bit may be asymptomatic. Most infants are asymptomatic at birth, but this definitely could be something that can cause sepsis. It can cause seizures. It can cause, of course, jaundice and other problems as well. Antiviral medications are prescribed for severe infections in the mother, but these medications are toxic and may only temporarily suppress the shedding of this virus itself. And lastly, H for herpes simplex virus. Whenever we have the virus itself, we are giving acyclovir to prevent recurrent outbreaks during pregnancy, or used to kind of suppress this in pregnancy to prevent an outbreak during our end of our third trimester itself. And the virus is usually transmitted to the fetus during the birth through the infected vagina or via an inciting infection after rupture of the membranes. If there are any active herpes lesions, they are doing no vaginal exams. That's just kind of what we do. Herpes can cause death or severe neural impairment of the newborn itself. So if we're usually having active lesions, we're going to be doing a C-section with our babies. Delivery of the fetus is usually C-section if active lesions are present, and delivery may be performed vaginally in the lesions that are in the anal, perineal, or inner thigh area as well. Kind of go into, whenever it comes to our exam 2 stuff with L&D, I would say focus on the powers. Definitely, I wouldn't put too much of an emphasis on the actual fetal lie of the baby itself, but we're going to kind of go through a little bit of this stuff. Whenever it comes to the well, I guess all the 4 pieces are kind of already here, but we're starting out with presentation. This is usually, we would always hope for head first because it's the most common. And of course, we do have some of those different types. We have a breech whenever it could be footling. That's usually when we're going to be doing a C-section, but it can have different kind of presentations of that as well. A lot of this stuff, I don't think they're going to ask too far in depth with this, so we're going to kind of skip over a little bit. Okay. We do have true and false labor. With true labor, the contractions may manifest as back pain, and they are usually a resemblance of menstrual cramps during early labor. So 352, I have it right here. Okay, yeah, the contractions are occurring regularly, they're becoming stronger, and they're lasting longer. Whenever with that false labor, it's kind of irregular. Sometimes it's relieved by certain things, and such as walking. Also, with our true labor, the fetus usually is becoming engaged in the pelvis and begins to kind of descend with that. That would, of course, lead to us having a cervical dilation and effacement that is becoming progressive. And of course, remember, effacement is a thinning of the cervix as well. Kind of moving forward a little bit. Alrighty. Whenever it comes to our different stages of labor, remember that we have different stages itself. And the first stage consists of 3 different phases, and it's always going to be in the, just think of latent active transition. We're going to kind of talk about that a little bit here. Latent, of course, is the strongest phase, the longest, I'm sorry. It is usually whenever with that first 1 to 4 centimeters. Pay attention to the timing of contractions, I would say, with all of these different 3 phases here. With the latent phase, the contractions are every 15 to 30 minutes, or about 15 to 30 seconds in duration, and are a mild intensity. This is whenever the mother could be definitely very comfortable. She might be still informing her partner about the progress. They're kind of, this is where it's pretty comfortable. They're kind of maybe even take some fluids and ice chips as well. But then we kind of get into the active phase. It's going to be of a moderate intensity as well. With the first 4 to 7 centimeters, the contractions are getting closer together, 3 to 5 minutes, and they are lasting a little bit longer. We're kind of almost doubled that length, where it's now 30 to 60 seconds. As far as the interventions go, we're getting into some breathing patterns. We're making sure we're promoting comfort, getting them in there, doing some back rubs, providing some support, and definitely just make sure that they're very comfortable for this. We go into the last phase of stage 1, where it's now the transition phase, where we're now to 8 to 10 centimeters. These contractions are definitely occurring every 2 to 3 minutes now, and they're even lasting up to 90 seconds, a very strong intensity. We're one of making sure that we're doing some rest between contractions. Sometimes the mother's going to be one of pushing, but you have to kind of get them to wait. We do see that. We see the fetal heart monitor and stuff like that, so we really have to kind of advocate for that and kind of doing some teaching on when it's right and when it's not right to push. We're offering ice chips, and we of course are encouraging them to void, because if they have a full bladder, that can definitely prevent the baby from descending. A lot of times when we have a mother that's been through an epidural, she'll already have a catheter put in, so that's kind of not a concern, but of course not everyone does get an epidural, so we have to kind of plan for that as well. Trying to find where I was going to go next. Okay, within stage 4 of pregnancy itself, so we're thinking postpartum, this is the period of 1 to 4 hours after birth. The blood pressure is kind of returning to that pre-labor level. The pulse is slightly lower than during labor. The fundus remains contracted in midline. And just kind of remember the thing here, it's going to be 1 or 2 finger breaths below the umbilicus. As far as interventions, I feel like it's pretty important because when we're thinking postpartum, we're thinking of getting ready and measuring blood loss, things like that. So we're performing assessments every 15 minutes for the first hour, every 30 minutes for the first hour, and hourly for 2 hours after that as well. We're making sure that we're providing warm blankets. We're going to be doing ice packs to the perineum, and we're massaging the uterus if needed, and teaching the mother to massage the uterus as well. That's kind of like what we're going to be doing, of course, with the whole bubble heat assessment, things like that. So just keep that in mind. Alrighty, going into anesthesia, and I feel like this definitely could be some questions, so we're going to hit on it real quick. When we're thinking about an epidural block, the block can cause hypotension, bladder distension in a prolonged second stage. The anesthetic does not cause a headache. Whenever you're hearing the term spinal headache, think of that, because of course the epidural is not the spinal. The epidural does not cause a headache because the dura mater is not penetrated. We are assessing that blood pressure though, and we're making sure that they're bladdering frequently as well. That's why we have going to be likely having our catheter put in. We're maintaining the mother in a sideline position or placed in a rolled blanket beneath the right hip to, of course, displace the uterus from the vena cava, considering and thinking about superior vena cava syndrome. We're going to be making sure they're getting fluids if hypotension does occur. Going into D with our spinal block, the block is administered just before birth. This anesthetic relieves uterine and perineal pain, and that's going to numb their entire, pretty much waist down, even to their lower extremities as well. This anesthetic may cause maternal hypotension and, of course, a spinal headache, the postpartum headache that it's saying here. The mother must lie flat for 8 to 12 hours after that spinal injection, and they are given IV fluids as prescribed. So just think about that as well. Alrighty. Next, talking about our Bishop score, because that's just a term that you might have remembered, but not knowing how to kind of evaluate this. The Bishop score is used to, of course, look at our readiness for labor, and we're looking at the entire cervical status itself. This is considering effacement. This is considering how far dilated they are and things like that as well. The Bishop score is indicated before an induction of labor. The 5 factors are assigned. It's going to be a score of 0 to 3, and the total score is calculated. A score of 6 or more indicates a readiness for labor induction. And as we go down over here, this is that actual score itself. So we're, of course, taking in their dilation. We're looking at how far effaced they are and percentage-wise, the consistency, the position, and the presenting part. Remembering that plus is going to be the lower. Think of the term +4 on the floor. Once they pass that ischial spine, it's going to be going into the descending process as well. So just that. With induction, the induction is the initiating of contractions. This is different than augmentation. This is going to be induction. So this is whenever we're kind of starting it itself. A lot of times they can have an elective induction where we're going to be just getting them on some Pitocin, some oxytocin. And we're, of course, we're increasing the dosage as prescribed only after assessing contractions. We have to assess the fetal heart rate as well before we do that. And we're looking at their blood pressure as well. It says, do not increase the rate of Pitocin, oxytocin when the desired contraction pattern is obtained. That would be 2 to 3 minutes and lasting 60 seconds. We have a little red checkpoint here that says an oxytocin infusion is discontinued if the uterine contraction frequency is less than 2 minutes or the duration is longer than 90 seconds. Just kind of a oxytocin question right there if you were to potentially have that. Alrighty. Going into kind of our complications of labor and birth. If we have a premature rupture of membranes, there's lots of teaching with this. The premature rupture of membranes refers to the, of course, spontaneous rupture of the amniotic fluid before the actual onset of labor. When the rupture of membranes is before term and birth, will be delayed. Infection is a risk. We have to really make sure that we are not doing lots of different vaginal exams with this. So that's where we're kind of going in here. With the interventions, we're assisting with tests to assess their gestational age. We're avoiding frequent vaginal exams because of the risk of infection. We are also monitoring the fetal status for signs of compromise or signs of infection as well. And they might be having to go on some antibiotics as well. With placental previa, remember this is going to be the painless one. As far as assessment goes itself, this is the sudden onset of a painless bright red vaginal bleed occurring in the last half of pregnancy. This is where the uterus is still going to be soft, relaxed, and non-tender. Although the fundal height may be more than expected for that gestational age. As far as what are we doing, we're assessing their vital signs, we're assessing the fetal heart rate. Those are always going to be two kind of gimmies, and then we're looking at fetal activity as well. We're preparing for an ultrasound to confirm the diagnosis, where they're going to actually go in and see the placenta itself. They are also doing a side lying position as prescribed. We're monitoring the signs of the amount of bleeding, looking for signs of shock. We're probably also going to be giving them on some fluids and maybe even giving some tocolytic medications to kind of stop that preterm labor. And we're going to see if we can kind of control this before it gets a little worse. If bleeding is very heavy and the pregnancy is imminent, we're going to be doing a C-section potentially to kind of help out with that as well. And it does say vaginal exams are contraindicated if the client is suspected or having known placenta previa. I would hope that we're already sure with the prolapse cord, knowing that we're going to be elevating and kind of raising that part. But if you're watching the video, this would be, if you like to pause it here for our priority nursing actions. We're going to be going into placental abruption next, because this can be a little tricky sometimes, because it's going to be like almost the same, but a little different. But when we're going into placental abruption for the assessment, this is the opposite. We're having now dark red vaginal bleeding. If the bleeding is high in the uterus or is minimal, there can be an absence of visible blood. Sorry. The uterine pain, this is going to have frequent uterine pain. This is that not fun one. This is going to be where it's going to be severe. We're looking for signs of fetal distress as well. And we're even looking for signs of shock if that bleeding is going to be excessive. For interventions, we're monitoring their same things, the vital signs and the fetal heart rate, assessing for excessive vaginal bleeding. We're looking for abdominal pain as well, and an increase in the fundal height as well. We're going to be keeping both of these on bed rest. We're giving oxygen, IV fluids, and blood products if needed. We're going to be placing this client in the Trendelenburg position, if indicated, to decrease the pressure of the fetus on that placenta itself. And with this one, we're preparing for delivery of the fetus as quickly as possible. With the vaginal delivery preferable, if the fetus is healthy. We might even be doing an emergency C-section if the fetus is alive but shows signs of fetal distress. We have here, note the differences between Previa and Abruption. In Previa, it's painless, bright red, and the uterus is soft, relaxed, and non-tender. In Abruption, there is dark red vaginal bleeding, uterine pain, tenderness, or both, and uterine rigidity as well. Keep going a little bit. We're just going on big topics, of course, whenever it comes to the actual studying. If you'd like to do more, if there's something that's kind of an issue with this, or with what you're kind of wanting to read more about, I would say this book is very helpful whenever it comes to studying for HESIs. We're going to be going into next to talking about uterine atony, because I think I do remember there being some questions on there as well. Okay, uterine atony itself is a poorly contracted uterus that does not compress large open vessels at the placental site. And when we're thinking about this, this is whenever we're thinking of a boggy uterus upon assessment. Okay, so whenever it comes to interventions, we're going to be doing massaging until firm, and we're emptying their bladder if that is what's contributing to our uterine atony. If we're massaging and it's not improving, we're thinking about potential hemorrhage, so we have to notify that provider. Going into our next section, hemorrhage and shock. If it is bleeding of 500 milliliters or more after delivery, this can occur during that first 24 hours or later than the first 24 hours following delivery as well. Whenever it comes to the overall assessment of that, this is whenever we're having a soaked pad within 15 minutes. They might have some assessments of potential shock, so we might be restless. An increased pulse, decreasing in blood pressure. They might be cool and clammy with a grayish color as well. They might be short of breath, might feel weak and lightheaded as well. Just signs of evidence bleeding occurring. We, of course, have this whole page here for the priority nursing actions and the, of course, different signs of our postpartum hemorrhage as well. And that's going to be it for the postpartum hemorrhage. I would say give it a good pause here. This is pretty much a lot right here, but think of it just as a normal shock. But I would say it's med-surg too, or hanging fluids and things like that as well. I wanted to bring up this picture to kind of explain the whole RH sensitization, if anyone still has any questions on that. So this is only when we're ever having an RH negative mom. If the RH factor in the mom is a positive, then this really is never an issue because they've already got those antigens present. So there's going to be no antibodies that can be made because they already have the antigens. Okay, so we have the mother here that's RH negative. The baby that's born, their dad's RH positive. So the baby's RH positive now. They are making these, you'll see these blue things here. This is when we have the antibodies being made on that first pregnancy. But let's go to the second pregnancy and we have another RH positive baby again. But this time on that second pregnancy, you'll see how the blue is now getting towards the fetus. This is where we have, this is why we give Rogam during the first 72 hours after birth. If that RH negative mother delivers a RH positive fetus but remains unsensitized. If they've already been sensitized, there's nothing we can really do as far as that. We're going to be doing some different meds I'm not too sure about. But as far as Sophia Hesse, this very well could be a question again. That's pretty much why Harold did put a lot of stress on this during their normal semester, okay? talking about newborn here, I would say I like to put a lot of stress on a hypoglycemia. This because there's lots of levels with this, and usually hypoglycemia is with a lot of our disease processes with our babies. Hypoglycemia is the low level of glucose in the body, less than 40 in the first 3 days of life, and less than 45 after the first 3 days of life. The normal blood glucose levels is going to be 40 to 60, and in a 1-day-old infant, it's going to be 50 to 90. Okay. Assessment of hypoglycemia is where we're going to be having an increased respiratory rate, twitching / tremors, unstable temperatures. They might even go into cyanosis, lethargic, apnea, and seizures. We're going to be administering formula orally or glucose IV as prescribed. We're monitoring them, and we are monitoring for, of course, all their signs and symptoms as well. For the newborn of a diabetic mom, the infant born to the mother with type 1 or type 2 diabetes, that would be the description. But we do have the assessment. They would have likely an excessive size and weight as a result of the excess fat and glycogen in their tissues. They might be on, of course, at risk for hypoglycemia. So we're kind of being on the lookout for that. Just kind of associating those two together. And that was going to be for that. Now we're going into some of the medication questions that I think would be very helpful. 417. All right. Just kind of talking over these questions because medications are, of course, all throughout OB, but we're going to be just talking about these here. These are the questions, of course, in the book itself, but let's, of course, just go through with them here. The nurse is monitoring a client who's receiving oxytocin to induce the labor. Which assessment finding should cause the nurse to immediately discontinue the oxytocin infusion? This is going to be starting out. For those that are online, I would say just pause it, try it yourself, and then we're going to, of course, talk about this rationale. This is going to be, remember how when you're getting oxytocin, you're at risk of hyperstimulating that uterus, making it too much, or also if there's going to be signs of fetal distress. So it would be 4 here, late decels in the fetal heart rate. Okay. Next, 335. A pregnant client is receiving mag sulfate for the magnesium management of a preeclampsia. The client determines that the client is experiencing toxicity from the med if these findings are noted on assessment. This is, of course, another SATA question. Okay, the answers for this question are going to be 2 and 4. And I'll just read the rationale so I don't make it any confusing at all. Mag toxicity is occurring from magnesium sulfate therapy. Signs of this relate to a CNS system being depressed. That's where we have number 2 there. Signs of respiratory depression, an absence of the deep tendon reflexes. That's why it wouldn't be 3. And then a sudden decline in the fetal heart rate and maternal heart rate and blood pressure. The respiratory rate below 12 is a sign of toxicity. The urine output should be at least 25 to 30 milliliters per hour. Proteinuria of 3+ is an expected finding for the infant. For the client with preeclampsia, because that's one of the signs. And the presence of a DT reflexes is normal and is an expected finding right now. That's what that would be. Okay, going into 336, the nurse asks a nursing student to describe the procedure for administering erythromycin ointment to the eyes of a newborn. Which student statement indicates further teaching is needed? The answer for this question is going to be 1. So pretty much this is a prophylactic treatment for our newborn here. The eyes are not going to be flushed after instillation of the medication because the flush would wash away all what was just done. Options 2, 3, and 4 are actually going to be correct regarding the procedure of erythromycin ointment. Okay, 337, a client in preterm labor who is dilated to 4 centimeters has been started on mag sulfate and the contractions have stopped. If the client's labor can be inhibited for the next 48 hours, the nurse anticipates a prescription for which med? So this is, think about, if you're still answering this question on the recording, I would say think about a steroid that can be given to help out the respiratory system of our newborn. So this is going to be betamethasone. Betamethasone is given to increase the production of the surfactant and stimulate fetal lung maturity as well. It's given to our clients in preterm labor at 28 to 32 weeks if the labor can be inhibited for 48 hours. Alrighty, next going into 338, methylorgonavine is prescribed for women to treat postpartum hemorrhage. Before administration of this med, what's the priority assessment? This is something that was actually on your exam 3. So this was a fairly easy question. This is going to be the answer. It's going to be 2, blood pressure. Just remember that the contraindication of this was going to be our hypertension. Okay, so that's why it's going to be 2. The book itself says methylorgonavine causes uterine contractions and may elevate the blood pressure. A priority assessment before the administration is to check the blood pressure. The healthcare provider needs to be notified if hypertension is present. Although 1, 3, and 4 may be components of the postpartum assessment, blood pressure is related specifically to the administration of this medication. The nurse is preparing exogenous surfactant to a premature infant who has respiratory distress syndrome. The nurse prepares the infant to administer by which route? This question here is actually, for those that are online, the answer is going to be 2, intratracheal. Respiratory distress syndrome is the serious condition causing immaturity and inability to produce surfactant, resulting in, of course, fetal hypoxia and potential acidosis. It's common in premature infants and may be due to lung immaturity as a result of surfactant deficiency. The mainstay treatment is the administration of this surfactant, which is administered by the tracheal route. That's going to be there. Okay, 340, the opioid analgesic is administered to a client in labor. The nurse assigned ensures that which medication is readily accessible should respiratory depression occur. As far as this question goes, the answer is going to be 1, understanding the opioid antagonist. So that's going to be naloxone. Okay. 341, Rogam is prescribed for a client after delivery, and the nurse provides information to the client about the purpose of this medication. The nurse determines that the woman understands the purpose of this. Woman states that it'll protect her baby from which condition? A fairly easy question. The answer on this is going to be D. Yes, D, being affected by the RH incompatibility. As far as the rationale of this, it goes, RH incompatibilities can occur when an RH negative mother becomes sensitized to the RH antigen. Sensitization may occur when an Rh negative woman becomes pregnant with a fetus who is Rh positive. During pregnancy and at delivery, some of the fetus's Rh positive blood can enter the maternal circulation, causing the mother's immune system to form antibodies against that Rh positive blood. We're giving RhoGAM to prevent the mother from developing these antibodies against the Rh positive blood by providing passive antibody protection against the Rh antigen. Okay, 342. Methylorganovine is prescribed for a client with postpartum hemorrhage. Before administering the medication, the nurse should contact the healthcare provider who prescribed the medication if which condition is documented and the client's medical history. All right. The answer for this one is going to be 4. Peripheral vascular disease. Methylorganovine is used to treat postpartum hemorrhage. Therefore, it is contraindicated in clients with significant cardiovascular disease, such as peripheral vascular disease. If they have hypertension, preeclampsia, or eclampsia, these conditions are worsened by the vasoconstrictive effects of this medication itself. So yeah, that's what that one would be. And lastly, 343 itself here, the nurse is monitoring the client in preterm labor who's receiving intravenous mag sulfate. The nurse should monitor for which adverse effect of this medication. Give it a little second. The answer for this one is going to be 1, 4, and 5, flushing, depressed respirations, and extreme muscle weakness. Starting out from the top, flushing. With mag sulfate, the adverse effects include flushing, depressed respirations, depressed deep tendon reflexes, hypotension, and extreme muscle weakness, decreased urinary output, pulmonary edema, and elevated serum magnesium levels. So that would explain why we have hypertension not being an answer. That would explain why we have an increased urine output not being an answer, because it's actually going to be the flip to those. And as well, the deep tendon reflexes, if adverse effects we're talking here, they're actually going to be decreased. Because I understand that with a client that was in preeclampsia, the tendon reflexes at first were hyperactive, but now that they've got this mag sulfate going for a long time, they're going to be having hyporeactive now. So that's what that's going to be. And that's going to be it for the actual little review session that I have here. I hope it is able to kind of bring some awareness to a little different topics as well. I'll actually still be posting I'll try to post another set of questions pretty soon before Monday. I wanted to say that if you have any concerns with certain topics, then definitely there is a Google Doc that has lots of different links to lots of different types of material. If there is any types of questions specifically, whether it's prenatal, L&D, postpartum, there is also a link to a free PDF that I did post within the Google Doc. You just have to go to the very top, and then it's going to say free practice questions here. You'll have to just view that document. It's going to be a Google Drive document. You can download it if you'd like. You don't have to. And that would help as well. There's a lot of resources, and I understand that it can be hectic, but if there's anything in particular that you're kind of, I wouldn't say scared for, but if there's anything that you're kind of stressed over, you can always look at that orange book is very helpful. If there's one resources that I did personally was I also used Your Best Grade. I used that for a little bit, and I looked over not necessarily the questions, because I felt like the questions were a lot harder on Your Best Grade than they were on the actual HESI. But I would say read those rationales if you have that resource already. If you don't have that resource, for the sake of OB, I wouldn't say purchase it just for this class. You can always get it later, because there is that free access to that little textbook that I did get you guys. And I would say that is a lot more helpful for the sake of the OB HESI itself. And that's what that's going to be. So if there's that, I would say good luck on your HESI. And I'm gonna go ahead and stop the recording now.